Now I will call Dr. Vikash Agrawal. He will be speaking on Lipid Association of India versus European Society of Cardiology lipid guidelines, key differences and update.
Thank you. Good morning. The topic given to me is the two different lipid guidelines, LAI guidelines versus ESC guidelines, some differences and some updates in 2025. Thank you. The epidemiology of atherosclerotic cardiovascular disease in India differs considerably from the same in the Western countries. And it is well recognized that the Indian developed ASCVD about a decade earlier than the Western population, despite having lower level of LDL cholesterol. And it has been reported that more than 50% of the CAD associated death in India occur before the age of 50 and 25% of MI occur before the age of 40 years. In the Interheart study, the median age of MI among Indians was 53 years compared to the 58.1 year from in other countries. This paragraph is taken from the LAI editorial. This is the first paragraph from the LAI editorials. I have mentioned it. Again, the part of epidemiology is about 25% of cardiovascular death in India is from the cardiovascular is CVD counts for 25% death among Indians. And the prevalence of the hypercholesterolemia in India varies from 10 to 15% in the rural and 25 to 30% in the urban population. The ICMR India study data is about 13.9% of the study population had hypercholesterolemia, in which high LDL is present in 11.8%. Other pictures like the low SDL, which is a very common up to 70% of the populations, and the high TG, which is about 30% of the populations. Now, part of the LAI first consensus present in the 2016, and in that time they have categorized 4 risks: low risk, moderate risk, high risk and very high risk. For the low risk and moderate risk, they have maintained the goal of LDL is less than 100, and for high risk they have maintained the goal less than 70, and for the very high risk they have maintained the goal less than 50 in 2016. 10 years prior, still the 25 European counterparts not reached that value. This is the very important slides. This is a 2023 updated part, and they have used different terminologies. If you look the pictures from the upper left, I think pictures are not very clear, but there is some word used: major ASCVD risk factors. There's a 4-point taken. Is because this slide is very important. If you look these slides, complete LAI is, I think you can cover it. Major ASCVD risk factors, there's a 4-point: age more than 45 in male and 55 in female, current smoking, high BP and low SDL. The second point word is high risk features. They have 8 word used: the family history of premature ASCVD, CKD stage 3B or 4, ApoB is above 130, extreme elevation of a single risk factors, LPA above 50, metabolic syndrome, non-alcoholic fatty liver disease with fibrosis grade 2 or 3, and coronary artery calcium scores 1 to 99 with less than 75th percentile. And the importance of this is high risk features. If any of the point is present, the goal should be maintained below 70. And this is a very common in our Indian populations with the metabolic syndrome, with an NFLD, with extreme elevation of a single risk factor. So any one of these high risk features, you should maintain the goal. This categorized in the high risk group. Any one of the high risk features, this categorize, the goal should be less than 70. There is some risk modifiers like the LPA 20 to 49, high polygenic risk score, rheumatoid arthritis, psoriasis, spondyloarthritis, they also have mentioned. Previously, not any European guidelines, they have mentions like this rheumatoid arthritis, psoriasis or spondyloarthritis as a risk modifiers, but LAI mention as a risk modifiers. Even they mention air pollution as a risk modifiers and HIV infections. Again, in the risk group, low risk, moderate risk, I am not covering it. For the high risk, if you look high risk, Like I have mentioned, any one of the high risk features, this is enter in the high risk groups where you can maintain the goal below 70. The second part is diabetic. With 0 to 1 major ASCVD risk factors, they have not mentioned any the duration of the diabetic. So any patients with diabetes, any persons with diabetes is come into the high risk groups where you maintain the goal below 70. But counterpart, if you look the European data, European informations, the short duration diabetes less than 10 years, they have mentioned the moderate risk group, long duration diabetic in the high risk group where the 10 more than 10-year data, and with target organ damage, this this is a very high risk group. So in LAI, any diabetic durations, they have mentioned high risk groups. Some very high risk groups like any ASCVD with obstructive or non-obstructive on the basis of coronary artery calcium scores, if value is more than 100, below 300, this is called very high risk. And the third part and the final part is the extreme risk, which is a further divided into three parts: extreme risk A, B and C. Extreme risk category A, where ASCVD risk with more than one feature of the high risk groups, coronary artery calcium scores more than 300, and the homozygous familial hypercholesterolemia. Heterozygous familial hypercholesterolemia, which is a very common in Indian population, is grouped in the very high risk group, but the homozygous in the extreme risk group where the goal is less than 50, and if you maintain less than 30, this is a further much better. For the category B, where ASCVD with recurrent ASCVS and with polyvascular disease, means along with CAD, there's maybe PAD, maybe cerebrovascular disease, and ASCVD with homozygous hypercholesterolemia. The third part is category C, where despite maintenance of the goal up to less than 30, if there is a higher chances of recurrence, you should maintain the goal below 10 to 15, and this is basis on the Fourier and Odyssey outcome programs. This is the risk category and lipid target around to according to the coronary artery calcium scores I have mentioned. If the score is 1 to 99, this is the moderate risk group where goal is less than 70. High risk group maintain the less than 70. If CSE scores is 100 to 299, maintain the goal less than 50, and if CSE scores is more than 300, maintain the goal around less than 30. The LAI guidelines and the management of ACS with ASCVD: perform lipid programs at the ED trials, means emergency department. Start upfront therapy with high intensity statin plus agitamib, and the reassess lipid profile 2 weeks and intensify every 2 weeks until the lipid goal is achieved, preferably by the 4 week. This is the same part, but here is one thing is different. Patients with statin intolerance, you start with the low dose statins plus agitamib, and if goal is not achieved within the 2 week, you can add the bempedoic acid plus minus PCSK9 inhibitors till the goal is achieved. But the important thing is you have to achieve the goal with upfront combinations along with the high intensity statin plus azitimib. This is the management of hypertriglyceridemia, further categorized in the three part: 200 to 499, 500 to 99, 999 and more than 1000. For the 200 to 499, managed with the statin plus minus azitimib, and they also manage with, if goal is not achieved, with fibrate and omega-3 fatty acids. But European counterpart not mention the fibrate as the priority. But if TZ is above 500 and above 1000, priority to the reduce the risk of the pancreatitis. So they mention fibrate, omega-3 fatty acids, icosapentaethyl, and if further goal is not achieved, you can add the saraglitazole. If further goal is not achieved, you have not any drugs like the volensorsins, which is present in the European populations. I have discovered these slides. LDL is the primary target, non-SDL is the co-primary target, and ApoB is the secondary target. This is important, and I have mentioned it too. This is very important things. LAI says regular lipid profile is screening is recommended starting at the age of 20 or from the college going individuals. And the screening should begin at the age of 2 for those with a family history of high cholesterol or premature coronary heart disease. The young age of onset and more aggressive nature of ASCVD in Indian necessitate emphasis on lifetime ASCVD risk instead of the conventional 10-year risk, which is a very common in the European counterpart and American counterpart. And it also demands early institution of aggressive preventive measures to protect the young population prior to the development of the ASCVD event. And the final point is very important. Indian subject, which is a more common for the metabolic associated disease, having higher non-HDL cholesterol and ApoB, and there is a very discordance between the LDL cholesterol and non-HDL cholesterol. So there is a more intensive lipid lowering is needed to achieve the non-HDL cholesterol target and ApoB target, providing it another rationale for the lowering of the LDL cholesterol. This is a very important. Maintaining LDL cholesterol around 70 from an early age is the crucial for the prevention of the heart disease. This is the core line from the LAI. And therefore LAI recommends lowering LDL cholesterol at an early age, and it will help reduce the lifelong risk of the major adverse cardiovascular event. The second point is about the ASC guidelines. I am coming with a very fast manner. They have incorporated score 2 and score 2 OP algorithms to improve the cardiovascular risk. For the ACS management, they also is very aggressive early combination therapy with high intensity statin plus agitamib. And in this ESC 25 update, they have a special focus to the HIV patients, chemotherapy patients, and acute coronary syndrome patients. For the LDL lowering therapy, bempedoic acid is added on new drugs, non-statin LLT drugs. On the basis of the clear outcome data, there is a good results with the MACE outcome in the statin intolerant patients. Evinacumab is also documented as a two-way guidelines for the homozygous familial hypercholesterolemia, because with the PCSK9 inhibitors, all the elarucumab, evolocumab, inclisiran, the data is not very good for the homozygous cholesterolemia. And the LPA is recommended as a routine measurement at least once in adulthood, and in the case of female patients, you can take the two times marker prior the menopause and the post menopause value. This is the 2019 value where the score criteria was used, and this replaced in the 2015 with the score 2 criteria. And according to the score 2 algorithms, they have decided moderate, high, very high risk. And here I have mentioned diabetic durations is important. Diabetic duration, short duration, moderate risk, high, long duration, high risk, and target organ damage with a very high risk. But in the Indian populations, any diabetic duration is considered as a high risk. This is some recommendations, newer recommendations. Class 1 score 2 and score 2 OP. Non-statin drugs with is combination is a class 1 recommendations for the ACS management. Bempedoic acid, if patient is intolerant to statin, is a class 1 recommendation. Evinacumab is a class 2A recommendations. Intensification of lipid lowering during index hospitalization is class 1 recommendation, which is a prior 2A. And the LPA above 50 is a risk enhancer, and is a greater increase in risk is a class 2A recommendation. Again, in these populations, you have no choice, but further stringent control to LDL is recommended. And the other guidelines, icosapentethyl 2 gram twice daily is a class 2A recommendations for the high TG value on the basis of reduced IT programs. And there is a one drug, newer drug, valensartan 300 milligram per week, above where the TG is above 750 to reduce the risk of pancreatitis is a class 2A recommendations. Some new things in the 25 update for the HIV infections is a primary cohort populations is a class 1 recommendations of the use of the statin, and basically they have used the pitavastatin is a very large population data, 8,000 population data, and the 35% MACE reductions were achieved in the HIV population. And the chemotherapy anthracycline based patients is a class 2A recommendations, and dietary supplements is the class 3 no use. This is some differences between the LAI versus ESC I have mentioned in my different slides. Risk stratifications, I have maintained all the things. Score 2 and score 2 OP tools used in the ESC. LAI generally not use any tools. They have mentioned their early risk assessment, prevalence of metabolic syndrome, age-related risk encountered in the Indian subject. Target, again, the target is a very target was used in the Indian populations less than 70, less than 50, less than 30, and compared to the ESC populations less than 55, less than 70 and less than 50 and less than 40. And all the things are I have mentioned these things. ApoB, non-SDL and LPA. LAI explicitly promote ApoB as an important secondary target, especially in diabetic mixed dyslipidemia, because our Indian population is very metabolic syndromic patients. ESC recommends LPA measurement at least once in life as a risk modifier and recognizes ApoB non-SDL as a useful alternative target. And thank you.
Sir, and there is a group of patients, let's say young patients less than 40 years of age, non-diabetic, non-hypertensive, non-smoker, but they come with the report of raised LDL level, like let's say 130, 141. So does the guideline recommend about these patients?
Again, on the basis of LDL, basically only on the LDL cholesterol. If LDL cholesterol is 130 to 160, 160 to 119, above 190, they have categorized moderate, high, and very high risk, isolated markers, irrespective of age.
So, what about the statin therapy in these patients?
For the moderate risk, you have to maintain the goal less than 100. For the high risk, less than 70, and for very high risk, less than 50.
What should be the duration of the dietary precautions and preventions before
Every time lifestyle modifications for the 3 months.
I just had a patient around the age of 45, female, diabetic. She was all the while doing quite okay, and she was on routine OHA, SGLT2, DPP4, all the stuff. Um, Suddenly, I discovered I was already giving her statin, atorvastatin with ezetimibe. Despite all the therapies, I just got her tested routinely just after the Diwali. Her triglycerides were 1400. 1400. I tested again from another lab. It was 1200.
You have
I can't explain.
you
I
have
was not able to
strict
explain.
you have strict lifestyle modifications, diet, exercise, and after that you add all the things, because there is a very high risk of pancreatitis. You add the statins for the LDL goals. After that, you have to omega-3 fatty acids, high doses, 2 into 2. You have to add the fibrate, and also I am recommending the same times you add the saroglitazole, because you have nothing extra drugs used there. So you have the 3 drugs in your basket for the TG: fibrates, omega-3 fatty acids, and saroglitazole. Thousands plus value, all the things along with the statin, along with diet, along with lifestyle modifications.
I also got a Homa IR done. Even that was also raised. So I was like, I don't know what happened. Just after the Diwali, I don't understand what could have triggered. Her Homa IR was moderately raised. She had insulin. I mean, even sugar levels shot up despite all therapy.
This is common. This is common with the metabolic syndromes like pictures and all things. So strict control of the diet, strict control of the carb diet, exercise, and all the things is very important. Because here the point of thing, you have to manage the chances of pancreatitis. Focus to the pancreatitis.
Yes. And another thing, what came to my mind, I would like to take your opinion on that. What about changes in the diet? Do you recommend that they should completely switch over to plant-based diet, or they should continue with?
I think you cannot. If your dietary pattern in your family is the same, you cannot completely change all the things. Otherwise, if there is a significant issue is occur, I think plant-based diet is best diet. But if you again, if the animal based diet, if you're taking the small quantity, if you taking the I cannot say completely about the diet pattern, but plant based diet is good. Again, if you take the animal based diet, the quantity is very important, frequency is very important, how you cook is important.
For
So, yes.
triglyceride more than 1000, the real risk is of pancreatitis, and mostly these patients are familial hypertriglyceridemia, and these patients requires lifelong therapy. And another important issue is reduction in carbohydrate is required.
Exactly.
That is very important aspect. And saroglitazole is a very effective drug. And statin is given to the all patients, and fibrates are also recommended, but fibrates along with statin, chances of myopathy becomes very high. So I prefer saroglitazole. It's a very effective drug, although it is not US FDA approved for hypertriglyceridemia, but now we are using for more than 15 years in India, and I have not seen any significant side effect. And it is and it is also reduces the glycosylated hemoglobin by zero point 0.5 to 1 in between. So it's very effective drug.
This is, if a part of the saroglitazole is a very balanced distribution of the part of alpha and gamma
Yeah.
action.
That's
So
the-
this is a good drug.
Another question, this bempedoic acid, uh, what has been your experience
As-
using
it's a good drug.
bempedoic with the statins as well?
Is good drugs. Why good drugs? Sometimes we cannot achieve the LDL goal close to 40, close to 30 as I required. PCSK9 inhibitors, no doubt, is a good drugs. Cost is a very significant issue. If your baseline LDL cholesterol is above 150 at the index point of time of the ACS, and you require the goal is less than 50, you have your basket LDL statin, which is about 50% reductions. The second drug is ezetimibe, which is about 20% additional reductions. But 70% reduction is not sufficient to maintain the goal from the 150 to the 50. So I think in some situations, the triple upfront therapy is very helpful. You can add the bempedoic acid in that mark. Sometimes patients not tolerating the high doses of statins, frequently in the real world data, in the real world scenario, if you look the book, if you look the informations, there is no such intolerant or statin intolerance there, because there is a definition. You have to intolerant to the two statins with the minimum statin doses. So here the bempedoic acid is a good role, and the part of bempedoic acid is a good role. The clear outcome data is a good informations. MACE reductions was seen, along with HSCRP was also reduced in the clear outcome program, which is not possible with the PCSK9 inhibitors. So this drug is good, no doubt.
There is chances of GB stone formation with the bempedoic
Additional
acid.
1% extra.
That we have to keep caution.
My one question to Dr. Vikas, phenofibrate has it got any mortality benefit despite of lowering the triglycerides?
If you use statin, if you use statin plus phenofibrate, there is no additional benefit of the mortality benefit. Prior to statins, yes, there is a non-fatal MI benefit was seen in the some group. But I think so with the statins, the data is not very sound with the CV mortality benefits.
One last point that I would like you to clarify. See, in autoimmune diseases like RA, we have lipid paradox, and the lipids are usually low in spite of
In the
having
acute
a high
situation,
risk
acute situation.
that you have already explained. But I just wanted to know, is there any level that we need to target for LDL?
I think in that scenario, some ratio is very informative. I think total cholesterol upon non-SDL cholesterol is more informative compared to the initial target like the LDL, non-SDL and ApoB. Here, ratio is important.
One last doubt. We have seen, I don't have a recommend, we don't know that if there is a guideline, but we have seen a lot of prescriptions where people prescribe statins like 5 by 7 days or a week or 6 by 7 days a week. Is there any rationale behind any scientific benefit of it?
No, I have not. Okay. I have not listened to these things. This is.
Please, ma'am.
Another thing what we get to see nowadays, which we used to never see, was pregnancy and abnormal lipids, especially triglycerides. What is your take on it? And do you recommend statins?
Absolutely not in the pregnancy.
Actually,
Until is the, I think Dr. Alok is giving much better answer.
It is very important to know during pregnancy time, all LDL cholesterol and everything is very high, even in normal. So recently, one of the physician have done a lipid profile, and all parameter was very high. Also, I was not aware. I was also stuck whether to treat or not. But I then underwent and reviewed the literature. Even your LDL can be as high as 250, and that is normal. You have not to treat because during fetal development, fetal brain development, because of that, these blood lipid levels are high. So until unless there is a known case of familial hypercholesterolemia in advance, we should try to avoid the treating these patients. And for the first time, we should not order lipid profile during the pregnancy because it will create more chaos rather than treating.
Very right. Thank you. Thank you very
Thank
much,
you.
Dr. Vikas.